Thank you all very much indeed for coming along to this Circle seminar. My name's Sue Yendall. I'm a Professor of Sociology and Director of the Centre for International Research on Care, Labour and Equalities at the University of Sheffield. And I'm also the Principal Investigator of the brand new ESRC Centre for Care. It's a delight to welcome Matthew to give today's Circle seminar. Matthew was an Innovation Fellow at Circle for 3 years between 2018 and the end of 2020, and then went on to his current post, which is Lecturer in Social Policy in the School for Policy Studies at the University of Bristol, where I believe he's continued to thrive. So I'm sure he will mention some of the new things that he's doing there. But Matthew's focus, both with us in his previous doctorate work and now, is around care and ageing futures, around geographies and materialities of care and caring, innovative design and evaluative approaches for digital health and care services, and digital transformation in health and social care arrangements and systems. So the very close alignment still between Matthew's interests and the work of the new Centre for Care, which will be recruiting more staff in the next few months, and will be telling all of you and others that follow us on our Twitter feed or on our website, which is in development at the moment, about the new work of the centre. But what Matthew's going to talk about today is the siloed communities of practice, as he calls them, in English technology-enabled care services. It's a great pleasure to give him the opportunity to talk about this subject, which is entitled Design and Implementation, Never the Twain Shall Meet. So over to you, Matthew. You're going to talk, I think, for about 40 odd minutes, and then we'll have time for discussion. Could I just remind people to make comments and include questions in the chat if they have them as things go along, so that Matthew can give his presentation uninterrupted. Thank you very much indeed.
Great. Thank you very much for that introduction, Sue. Great to see you and Circle colleagues again, and also people who I don't know in the audience today. I'm calling from Sheffield, even though I now work in Bristol. I'm still very much living in Sheffield. It's a nice sunny day, but very blustery outside. So hopefully the connection works well for the whole presentation. So it's great to be here again. And thank you again, Sue and the Circle colleagues, for inviting me to this talk. My talk today, as Sue described, is Design and Implementation, Never the Twain Shall Meet, ? We'll discuss today, looking at the siloed communities of practice between people who are involved in design and development of technologies and those who are involved in implementation of such technologies within housing and care services, especially in social care within England. So a bit of background. So much of the time when we hear about the current situation of social care within this country, it is often framed as one within crisis. There's an ongoing dialogue that's been happening for a better part of a decade now and has reached increasing tipping points sporadically over that same period of time, particularly now so during the COVID-19 pandemic. One thing that we are constantly hearing is the possibility of technology for alleviating some pressures within the social care system, both within organizations, but also for individual arrangements for people who receive said services. So a lot of time when we think about it in policy, but also within popular press, is often framed as technology as being this kind of panacea, which is going to solve all the issues, and with robots, artificial intelligence, and other digital technologies being seen as kind of the future versions of providing care. And for my work, both my doctoral work, my work I did at the University of Sheffield as an Innovation Fellow, and my ongoing work is really interrogating the possibilities of care in the future and the role of technologies broadly defined in helping us to meet new care futures that we would want to experience and live with. So tied to that, I'm going to talk about very briefly about my doctoral study, which is called Accommodate, which is an acronym for a collaborative community-based ethnography with people with dementia and their carers using assistive technology and telecare in England. We love an acronym, so that's why it's shortened down very much to Accommodate there. I'm going to talk about this very briefly as getting foregrounding my work I did at Sheffield, looking at design and implementation of technologies. So what was this accommodate? I gave the acronym for you again, but what it was an embedded ethnography, which was a qualitative approach, spending time with people living with dementia and their carers, living in the community in parts of the east of England and also London, and looking at how they actually using these technologies within their lives, right? So it was examining the practices of people with dementia and their carers, but also looking at how they talk about how they made sense of these technologies in their lives. And this was embedded, I say, because it was a qualitative element within a national randomized controlled trial called Attila, which is, again, another acronym, of course, talking about assistive technology and telecare to maintain independent living at home for people with dementia. So while the trial was very much interested in, are assistive technologies and telecare cost effective? Are they clinically effective in helping people to maintain independent living in their own homes? I was interested as the ethnographer being, what happens with technology once you give it to them in their homes, right? Do people with dementia actually use it? Do they throw in the cupboards and never see the light of day again? And what changes to the dynamic of the built environment, the relationships, how they're experiencing care in everyday life within this community-based setting, within their own homes? So to explore these issues, I completed 208 hours of observation involving 9 cases of people with dementia and their family carers over a 6-month period. The 208 hours were mainly based upon interview transcripts and also field notes, which were analyzed using situational analysis, so actually looking at situated practices within relationships in these built environments. And through this analysis, I identified 3 broad themes. So placing care, replacing care, and displacing care. Now, I don't want to spend too much time on this preliminary research. So I'm going to focus on just the final theme there, displacing care, for the purposes of this presentation. And displacing care was really well illustrated through this evocative case of the Drapers. These are pseudonyms that I applied to this particular case. And through this case, I really want you to see how rooms, and tied to these rooms, the practices of caring and living with dementia became reconfigured through abandonment and resettling in these different spaces. So when I first started my fieldwork with the Draper family, that is Violet, who was an older woman living with dementia at home. And this is in her detached house in the east of England, and with her primary care, her adult son, Thomas, who did not live with her, but lived in a neighboring village and actually quit his job in order to care for his mother full time. What you'll see here is that shortly before I started my fieldwork in September 2015, unfortunately, Violet had a terrible fall, which resulted in her breaking both of her legs. I'm sorry, breaking just one of her leg at that point in time. As a result of this, rather than making her go upstairs, given the difficulty she had with mobilizing, Thomas made a decision to move a bed into the lounge or sitting room of her house. Effectively, this meant when I visited her and Thomas that I was not just in the sitting room, but the sitting room come bedroom as well. So it had both these dual functions as a result of this. For the trial, she was given a calendar clock because one of the challenges she was facing was orientation. She would often call her son in the middle of the night, thinking it was in the afternoon. So 2 a.m. is very different from 2 p.m. For a person who has to get up early in the morning. So this is one of the issues there. Fast forward to the next month. At this point in time, actually, is when Violet had another bad fall, resulting in hospitalization. Therefore, when I went to visit the Draper family, I was only able to meet with Thomas in this time. They were anticipating Violet being able to come back to her home soon. In preparation for that, they had put a commode in place in order to help her with her toileting needs, because the toilet, unfortunately for this house, was only upstairs. And due to her limitations with being able to mobilize, they thought it would be best for her to have a commode in place. But you're seeing how the accumulation of different material objects there is shaping the spaces in this room, right? So it's going from a sitting room and bedroom, and now sitting room, bedroom and also bathroom or toilet space now too, right? But it's still maintaining all these different functionalities there for this study, and for this family unit. Unfortunately, by the time of my final visit in April of 2016, what had happened is they made the decision that Violet was no longer able to live with the support that her son could provide to her at home. And there's no viable options, according to Thomas, for home care to be provided for her that was acute enough to meet her needs. So they made a decision to place Violet into permanent residential care. During my final visit here, Thomas had made a decision also to sell what was his family home and Violet's home in her later years in order to finance the costs for her care home. So I visited there. Everything had already been packed up. The only things that remained in the space beyond packed up boxes was an electronic bed, the commode, and that calendar clock at the time. So why I wanted to show you this is because the findings from that study really problematized what living independently in the community meant, right? So people with dementia in this case really left their homes, or indeed if they did leave their homes, is because they were residing somewhere else, right? In a hospital or in a residential care facility. But also highlights the role of carers in reconfiguring the home, right? These domestic spaces to meet the shifting care needs of people living with dementia. And I really like this idea of participants had to continuously make assistive technology and telecare fit, right? They had to tinker with these devices in order to make sure that they fit within domestic spaces, places, and routines, both caring and everyday, to make sure it fit into their lives. Now, what this did for me is it prompted further questions about, given everything that's happened in a person living with dementia's life, or any older person more broadly too, how should we design and implement care technologies which can adapt to the changing spaces and places of care in later life, including people with a cognitive impairment, which may have very precise and variegated needs compared to other people as well. So with that kind of context in place, I basically wanted to come down with how do we make sure we don't design technologies that look like this robot right here, which just functionally may do the job, but it may uncover all kind of dystopian imaginaries we have as well about the limitations about technology within care too. So how can we design technologies which help us be care for or care for a person in the ways we'd want to be? And that brings me to the study I completed at the University of Sheffield. So this was called Accelerating Implementation Uptake of New Technologies to Support Aging in Place, ASAP, if you prefer another acronym again. And what this study was an innovation fellowship, as Sue has already indicated before, which is linked to the ESRC large grant, Sustainable Care, Connecting People and Systems, a large grant that just ended, I think, May last year, or August last year, which Sue was the principal investigator for, and many people on this call were co-investigators as well. So while Sustainable Care is looking at a range of different possibilities for how to make adult social care systems in particular more sustainable, my fellowship was tied to looking at the challenges and opportunities of technology-enabled care services and the ecosystem, and how it related or not to different social imaginaries about how we saw technology and its intersection with aging societies and futures of caring too. To investigate this, I took on a participatory action research approach, which involved, again, building upon that embedded ethnography for my PhD, but we're now rather than embedding in the lives of older people with dementia or carers, so what we might call service users or technology users. Instead, it's very much focused on embedding within different organizations instead, so more of an organizational ethnography approach, including people involved in housing care providers, technology developers, and including new startups, but also advocacy third sector groups, and also think tanks and policymakers too. So for ASAP, I had a few key research questions. I want to investigate what the roles were of innovative and emergent technologies in care. And indeed, you can put scare quotes around, what makes technology innovative and what makes it emergent, based upon how it is situated in different contexts. But particularly I wanted to look at how and to what extent will robots, apps, digital monitoring technologies, and Internet of Things support well-being of those receiving and providing care, right? Something that is enshrined within legal frameworks like the CARE Act from 2014, but also importantly, looking at sustainability in other ways to beyond financial security, looking at sustainability of care relationships and care work and caring at a distance as well. Since technology is often championed and heralded as this solution for helping care to be situated across differences, right? Helping to kind of fold the time and space required to do care work. I want to see how the implications for that translates into what it means for those caring relationships, both professionally, but also within family and kin-based caring too. The second question was looking at the challenges and opportunities for technology-enabled care as an industry or sector, right? So what do people who are currently providing technologies, providing housing or care services, or people involved in policymaking, or indeed in industry, view as challenges within the organization, perhaps endemically within that, but also more widely across the wider ecosystem too, contemporary, but also forecasting based upon what they anticipate happening in the future too. And finally, kind of building upon the responses and the findings from those two first major questions is, how can, does, or indeed should technology enable care and aging in place, right? So this is, I think, the major role there is, what does it mean to have technology enabling care? What does care mean to us as a species, but also has become formalized and bureaucratized within systems? And how does technology help to facilitate those different imaginaries? And what is the role of social research to meaningfully intervene, therefore, in the design, manufacturing, procurement, provision of these different emergent and future technologies? How will these technologies shape futures of caring, right? So thinking beyond these technologies as intervention or solution, and thinking about actually by having these technologies in place, how's it reconfiguring how we perceive the possibilities of caring and how we provide care, and then who ultimately will benefit from these shifts as well. Tied to this project where numerous study partners, which are all in public domain, so it's fine for me to say this. The first was Technology-Enabled Care Services Association, which is formerly the Telecare Services Association, which still goes by the acronym TSA, which many of you on this call may know about. It's an industrial body that champions technology-enabled care products. It offers advice and guidance around technology-enabled care, especially around procurement, marketing, and it is trying to inspire the care sector and encourage innovation, looking at new possibilities for how technology can help to shape system sustainability. Another partner was Consequential Robotics. This is a spin-off from the University of Sheffield, although it's currently based at the Robotics Laboratory in Bristol. This focuses on developing assistive robotic systems that will enhance quality of life as people age and aims to bring emotionally engaging, useful, and aspirational robot solutions. One thing that's interesting about Consequential Robotics is the technology they have developed, which actually was the mirror robot you saw in that Guardian article at the beginning of this presentation, is rather than trying to focus on mimicking human behavior and human thought processes through artificial intelligence, is they are focusing on animal behavior replication. They see that as one way of kind of helping to avoid the uncanny valley, which is what we call it when things can look a bit humanoid, but perhaps not humanoid enough to actually passing as human, and therefore that can be a bit of an unsettling kind of experience interacting with those kind of robots. So the argument is that by working on with things that are more animal-like, we may not have to deal with such an uncanny valley, but they're looking at how to therefore implement those kind of technologies to support people within care settings, especially later in life. Another partner, of course, was Carers UK, who is a charity representing carers across the whole UK. They see technology as a vital aspect of how you modernize potential caring solutions in the future, and also advocate on behalf of carers, of course, as well. And then I also worked with Housing 2021, Johnny Johnson, and Asterline, which is a technology-based company with Johnny Johnson, and these are providers of services who see technology as pivotal to how they will provide and modernize their services going forward. So for my study, there were numerous participant groups, and I've gone through by organizations instead. So I had involved 2 think tanks or policymaker groups within my study. I involved 4 businesses. These are technology and ill care businesses, so these are actually tech providers in their own right. I involved 2 housing and care providers, and also 3 third sector organizations, advocacy groups, or charities. That is to say that within these organizations, I did interviews and observations with multiple different individuals. But it was through the organizational kind of capacity in which I wanted to view things in order to then kind of see what's happening within organizations, but also what's happening across the whole sector too. So the first finding I'm going to talk about is the idea of curated systems and Salem products. So one of the emerging features, especially from the role of housing and care providers, is the shift from having what I've heard other people characterize at TSA conferences as the thing in the box, right? So it's moving past having a single device for lots of different things. So, having a hoist, having a telecare product, having an activity monitoring system like just checking, having a pendant alarm as well. So rather than having lots of different products in your home, it's about having perhaps a single device which to interface with, and having that either have lots of different apps on it, or how it can connect to other technologies in a more smart way. So kind of at least a proof of concept of an Internet of Things type of device where you have a central hub which then connect to other systems. And this is more about curating systems, therefore, instead of having standalone products. Tied to this particular finding is the idea that Alliance curated systems are not purpose-built to be care technologies. Many of them are consumer technologies. We're seeing a proliferation of things developed by Amazon, like Alexa and Dot ecosystems. We're seeing increasing role of Microsoft and also in Google and entering into these spaces as well. And this is often at odds with how technologies have historically been designed and provided within these spaces. We think about legacy telecare products like Tunstall, Legrand, who are major players both in the UK but also internationally, especially in Europe. It is the proliferation of these consumer products which is blurring perhaps the distinction between what does it mean to be a care technology, which in this study, which I did not have a chance to investigate further, I think raises further questions about, well, how does one then regulate these technologies, right? How do you go from regulating an Amazon, which has originally been used as perhaps an older person living at home for kind of everyday kind of tasks, learning about the weather, news, listening to music, to one which then may be used in more of a caring capacity to inform them about their health and care options. More further information about that. What are the implications for that, for how that's regulated and controlled? What are the implications for safeguarding? What are the implications for how a local authority then interfaces these products with their systems? And of course, another major issue too is what are the roles for using public money to fund some of these offerings, given that some of these companies do, especially in the consumer domain, do not pay taxes in this country as well. So there's kind of some unsettlingness from some people who are frontline staff about the opportunities in these technologies, but also what are the costs, both social and material, and having them rolled out more widely. The third finding I'm going to mention is really tying to working with new startups. And this came across as a limited understanding of experiences of care in later life. A lot of people I work with who are new startups tend to be living within the kind of golden triangle of London, Cambridge, and Oxford, which isn't too surprising, because that's where a lot of technology innovation does happen within this country. Oftentimes these new developers were often white, male, in their 20s or 30s. And as a result of this, they often came from a business background or engineering, they didn't necessarily have the lived experience of providing care, or obviously being an older person in their own right, given that they were often a younger person. But critically, they also didn't often have the networks in place to figure out how could one learn about the desires, ambitions of people within those situations, in order to inform the design of these other technologies, and how to develop, therefore, technology to support older populations. So that's seen as a major issue, therefore, for how we're thinking about these imaginaries of caring, right? If it is based upon people who are relatively young, able-bodied, male, which often is contrary to the demographics we know about people who are carers, who tend to be majority female, increasingly people of color as well, often from a migrant status as well. What is the connection they're making between their perceived imaginaries about what it's like to be an older person, what it's like to receive care or provide care, versus the actual material realities of that for people involved in those practices? Another major issue when it came to startups is anxieties about how do you move beyond this palladitis stage. And I will credit Simon Bottery, who I believe, to my knowledge, is the person who came up with this palladitis term, which I think is brilliant. It's really kind of defining what seems to be this interminable stage a lot of new tech developers get to, where they can get some initial capital raised to develop a low fidelity, maybe even a high fidelity prototype of their product. They can generate some initial interest within a local authority or a service provider organization. They might even do an evaluation of that as well. But then, depending upon the success of that, whether it is deemed as a success or failure or somewhere moderated in between there, it's how do you move beyond that to actually scale up and spread this technology more widely into other services, into other regions of the country. An important tie to that is, what are the connections between evidence? So what is sufficient evidence to say it is a good product? It can be implemented well in services. But also knowledge about what does implementing even look like, right? How do you talk to local authority? What do you understand about the procurement processes for an individual local authority? What do you understand about them across different regions as well? What are the roles of STPs, integrated care systems, all these other things you may not know about if you are new to adult social care as a system? And how do you start to develop these skills and mobilize them into a practice so you can actually make meaningful business decisions for you as well? And tied to this is this uncertainty about how do we evaluate tech products, right? These technology-enabled care products. How do we know something is a good product? How do we know that it has the right outcomes for the right people? One thing I noticed through both previous work, but also through this fellowship, is that technology-enabled care products or assistive technology, telecare, are often evaluated based on health-related outcomes, right? Health-related quality of life, the EQ5D to look at well-being outcomes, looking at cost-effectiveness as well. There seems to be much less of an emphasis on looking at care-related outcomes. Is this technology helping to facilitate or coordinate care better, right? Or well-being-based outcomes. Is it actually having an effect on the person's material, subjective, or social well-being, or financial well-being, right? What is the role of technology in helping to facilitate those things? So how is it moving beyond health services, health-related outcomes, to actually asking the right questions about evidencing technologies within social care systems? So from these findings, there were a few insights I think that were generated as well. So first of all, which tied to the title of this paper, is this tension between people providing tech within services. So these are both tech providers, but also tech providers who often are working in partnership with housing and social care providers too. And also those people who are designing and developing technology products as well, right? They often may have a similar goal, but the language, the values, and the models, business models, care models, are often very divergent, and also often operated in isolation as well. So it's potentially a good outcome for people that tech providers are beginning to focus more on curated systems rather than standalone products. So you need to have lots of different widgets in your house doing lots of different things. It can be more streamlined potentially through using these technologies. But how does one learn about new opportunities, new technologies? One thing I've uncovered is the central role of technology-enabled care champions, often embedded in local authorities, generally a social worker or occupational therapist by training, and the importance of that role when it is available. Not every local authority has one, to identify new products and service delivery options. But oftentimes these tech champions are reliant on marketing material, conference attendance from different exhibitors to inform the decisions about what is the best new technologies to potentially recommend for their services. So it's not necessarily informed by evidence, either from academic research or policy analysis, to think about how this technology can be transformative. And for the other group of people involved in this study, predominantly tech developers who are new startups, who, again, may be the possible service innovators of the future, they appear to lack this knowledge, network, and the skills. And when they did have those, they still often lack the ability to mobilize them, to translate them into something, to meaningful practice, which often inhibited their way to both understand the care system, but also to continue down pathways towards procurement, and also localized service delivery models in order to sustain their business. So how do you actually have a business for tech companies if you're not sure how to actually get your products to the market? So one thing I wanted to touch on now is how might we fix some of these issues? And what I suggested in the abstract for this is the idea of co-production, or what people in health services might call patient and public involvement. So it became clear to me that new startups require additional support to learn about the social care system. And so especially new startup tech developers, they recognize the need to work with people with experience, right? So they recognize that co-production is kind of the gold standard for how to design good products, right, based upon how people want to live their lives. But again, they often lack that knowledge and social capital to engage with such groups. How do you work to identify the right model user to test out your equipment? How do you work with different local authorities or broader national groups like ADAS to help you figure out how to get your product to market? So what I'm suggesting, what I plan to investigate in future work is how can we join up then these isolated styles of practice? How can we join up people from that technology developer, either as engineers or designers, side of actually creating new technological products, with the other kind of isolated community practice there from people who are involved in implementation, right? So these are tech champions, but these are also care managers. These are directors of adult social services. These are frontline staff, right? Occupational therapists, social workers who may be doing the assessments and actually recommending different technologies. How can we make sure that these people, these different organizations, these different communities have a shared language, a shared value system to help co-inform each other to make sure that what is being produced of technology is addressing the needs of services, of end users within those services, care recipients, but also how do we make sure that tech developers have the knowledge required to know how to access that. So perhaps co-production as a form of brokerage, as change agent is an opportunity there as well. So that's where I'm going to end it for today. I can go into more detail about my current research plans and questions if you want to. But I just wanted to thank you for your attention and also gratefully acknowledge the contribution from the Economic and Social Research Council and the University of Sheffield, which helped to support and fund this research. So thank you very much.
Thank you very much, Matthew. And thank you for that really clear exposition of both your doctoral studies and some of the things you learned there.